Hello dear students, this is Dr. Santosh Patil, and in this video module let me address hepatopulmonary syndrome, one of the emerging topics when it comes to NEET super specialty. Okay, now as the title of the disease suggests, we're talking about an entity where the lungs are affected secondary to liver pathology. But now there's also another condition which has lung involvement secondary to liver pathology, and clinical presentation may be a bit similar, mainly in terms of hypoxia and dyspnea as the complaints with the backdrop of liver disease. So at the end of this video module, we should be able to differentiate hepatopulmonary syndrome from another entity that I'm talking about, right? Which entity I'm talking about? Right, I'm talking about portopulmonary hypertension, right? So as the name suggests, portopulmonary hypertension means patient has developed pulmonary hypertension in presence of portal hypertension, right? So when we try to dissect the definition, things become pretty clear. So let us first dissect the definition of hepatopulmonary syndrome and then we will move on further. Okay, now what is hepatopulmonary syndrome? By definition, hepatopulmonary syndrome is a condition where there is type 1 respiratory failure or hypoxic respiratory failure, hypoxic respiratory failure. Please remember, with increased alveolar arterial oxygen gradient, and this hypoxia and increase in alveolar arterial oxygen gradient is happening due to pulmonary vasodilatation. So this explains what is happening with respect to lung. Now this has to be linked to liver, right? So all this should be happening in presence of liver disease or portal hypertension. Okay, now there's a reason why I am saying it as liver disease or portal hypertension instead of saying liver disease with portal hypertension. Well, I do agree that most cases of hepatopulmonary syndrome are diagnosed in patients with CLD and portal hypertension. But we have to also remember that hepatopulmonary syndrome can also occur in patients who have acute liver failure, right? In ALF patients also we can see hepatopulmonary syndrome. At the same time, we can see hepatopulmonary syndrome in patients who have non-cirrhotic portal hypertension. That is why this definition I'm saying liver disease or portal hypertension, right? Any one of them present is also sufficient enough to lead to hepatopulmonary syndrome. Though most cases it is CLD with portal hypertension is where we will be seeing hepatopulmonary syndrome. Okay, now before discussing the pathophysiology, etiology and all, let me address the diagnostic criteria. Again, there is a reason why I'm addressing diagnostic criteria soon after definition. It makes things easier and it is also like kind of easier to remember stuff when we try to link it with the definition. Okay, now when you pay attention to definition, tell me what all you need for the diagnosis of hepatopulmonary syndrome. So the definition mandates that there should be hypoxia, right? And obviously, just like in ARDS, where we are taking the PaO2 by FiO2 ratio for defining hypoxia, here also we might have some objective number, right? Just randomly, we're not calling it as hypoxia. There should be an objective number. So that will be the first criteria. The second criteria that we need to meet is, as the definition says, there should be pulmonary vasodilatation, right? So we need an objective evidence to say that there is pulmonary vasodilatation. Second criteria. Then the third criteria is there should be evidence of liver disease or portal hypertension. So when all these three things come together, we diagnose hepatopulmonary syndrome: hypoxia, pulmonary vasodilatation, liver disease or portal hypertension, right? Okay, so now let me pen down the diagnostic criteria. What is the number one diagnostic criteria? There should be hypoxia, and here we are looking at PaO2 and alveolar and arterial oxygen gradient. So when PaO2 is less than 80 millimeters of mercury, or, right, please again pay attention, I'm saying or, alveolar arterial oxygen gradient more than 15 millimeters of mercury. That satisfies the hypoxia component of the definition, right? That's the first diagnostic criteria. And now remember, even if the PaO2 is more than 80 millimeters of mercury, if the alveolar arterial oxygen gradient is more than 15 millimeters of mercury, that still satisfies the criteria number one, right? Okay. Now, the second criteria, we need the evidence of pulmonary vasodilatation. Yeah, I forgot to tell you one important thing. So when I am talking about the PaO2 and alveolar arterial oxygen gradient, we have to remember here that number one, patient should be in sitting posture or sitting position. You will understand more on this when we later discuss about the clinical feature, why we want the patient to be in sitting posture. But right now, remember that patient should be in sitting posture, not in the recumbent posture. And second thing, that this should be done while patient is breathing on room air or ambient air. Breathing on room air or ambient air, not with your oxygen supplementation. Okay, criteria number one is clear. Now the second thing we needed for the diagnosis was pulmonary vasodilatation. Now how do we document that there is pulmonary vasodilatation? That can be documented by two methods. Okay, number one is the gold standard method, which is nothing but what we call as contrast enhanced echocardiogram, where we are using agitated saline, or you can also call it as bubble contrast echo. We can also call it as bubble contrast echo. The parameters I will discuss when we discuss the evaluation. That can be one way of documenting that there is pulmonary vasodilatation. Or second, we can also look at radioactive lung perfusion scan. Radioactive lung perfusion scan. Okay, radioactive lung perfusion scan using radio labeled albumin. And here I want you to remember one number. Okay, I'm not getting into the very detailed discussion of the nuclear medicine here. Just remember one number. With brain shunt quantity more than 6%. Like when we do this radioactive lung perfusion scan, right, we will get to know like to what percentage different organs are receiving this radio labeled albumin. Now when it is more than 6% to the brain, that is suggestive of hepatopulmonary syndrome. Okay, now that is the second criteria, pulmonary vasodilatation, and most commonly we are going with the bubble contrast echo, or what we also call as contrast enhanced echo, or sometimes we also address it as agitated saline echo, right? That's the best investigation for documentation of pulmonary vasodilatation. Third thing is we need to prove that there is liver disease or portal hypertension. So when these three criteria are met, we made a diagnosis of hepatopulmonary syndrome. Okay, that's clear. Diagnosis is done. Now again, before moving on to discuss the pathophysiology, etiology and all, let us also understand the severity of hepatopulmonary syndrome. Okay, now we're talking about a condition where the defining feature is hypoxemia. So when hypoxemia is the defining feature, obviously the severity will also be classified based on the hypoxemia degree itself, right? Like in case of ARDS, PaO2 by FiO2 ratio was used for the diagnosis. Severity classification was also based on the PaO2 by FiO2 ratio. Now here also we will be following the PaO2 because that is what we used for the definition of the disease, right? Okay, now when can I call it as mild hepatopulmonary syndrome? I will call it as mild hepatopulmonary syndrome when PaO2 is more than 80 millimeters of mercury with alveolar arterial oxygen gradient of more than 15 millimeters of mercury. Okay, so does this satisfy the diagnostic criteria? Yes, right? When you look at the diagnostic criteria, what did we say? Either PaO2 less than 80 or alveolar arterial oxygen gradient of more than 15 millimeters of mercury. So the mild case obviously satisfies that, right? Okay, I will call it as mild in this case. Now second, I will call it as moderate when PaO2 is more than or equal to 60 millimeters of mercury but less than 80 millimeters of mercury. Okay, we will call it as moderate, obviously with alveolar arterial oxygen gradient of more than 15 millimeters of mercury. Okay, now when can I call it as severe? I will call it as severe when PaO2 is more than or equal to 50 but less than 60 millimeters of mercury with my alveolar arterial gradient of more than 15 millimeters of mercury. Okay, now this is how I define mild, moderate, severe, but there is also very severe. Okay, now for very severe, apart from the simplistic PaO2 reading, we have one extra reading to remember. Okay, now before going there, please remember one important point. Now when I am saying that PaO2 more than 80 or 60 to 80 or 50 to 60, all this is based on room air breathing and patient in sitting posture, right? That is what we also used for the definition or the diagnostic criteria. On room air. Okay, now if the patient continues to be on room air, then when PaO2 is less than 50 millimeters of mercury and I have my alveolar arterial gradient of more than 15 millimeters of mercury, that will also be counted as severe, very severe, right? So please remember, very severe when it is less than 50, when patient is breathing on room air. But what happens in clinical practice is patients who have very severe hepatopulmonary syndrome, right? When they come to us, they may already be on the oxygen supplementation, and the situation may not permit us to discontinue the oxygen. So we should probably make a diagnosis of hepatopulmonary syndrome while patient being on oxygen, right? So for that, we have another parameter to remember here. So when PaO2 is less than 300 millimeters of mercury with patient breathing 100% oxygen, or in other words, the FiO2 is 100%. So if the patient is on FiO2 100% and the ABG shows PaO2 less than 300 millimeters of mercury, we would rather call it as very severe hepatopulmonary syndrome, right? So this is a very valid point when it comes to clinical practice, right? When you have severe or very severe hepatopulmonary syndrome patient, it may be very technically difficult to discontinue the oxygen and then get an ABG done. So instead, what we can do is they may be getting 40% FiO2, 50%, 30%, or whatever, 60%, escalate it to 100% and then get an ABG done. And if the ABG shows that PaO2 is less than 300 millimeters of mercury, well, you have a case of very severe hepatopulmonary syndrome. Okay, so now what we know so far, we understand what is the definition, right? Definition says hypoxemia with increased alveolar arterial oxygen gradient due to pulmonary vasodilatation in presence of liver disease or portal hypertension. Okay, diagnostic criteria, we proved the same three components of the definition: PaO2 less than 80 or a gradient of more than 15 while patient on a sitting posture, breathing room air. We also proved that there is pulmonary vasodilatation using the bubble contrast echo, and patient should have liver disease or portal hypertension. Severity classification is based on the PaO2. PaO2 more than 80 mild, 60 to 80 moderate, 50 to 60 severe, and less than 50 very severe when patient is breathing on room air and his alveolar arterial oxygen gradient is more than 15 millimeters of mercury, right? Okay, but also when patient is on 100% FiO2, if the PaO2 is less than 300 millimeters of mercury, that patient will also qualify to be called as very severe hepatopulmonary syndrome. Clear? Okay, now comes the question, why all this is happening, right? Ultimately, the final issue here is vasodilatation, and in the definition I did not include the second critical issue in patients with hepatopulmonary syndrome, and that is development of vascular shunts inside the pulmonary vasculature. Shunts and vasodilatation, these are the two critical problems in hepatopulmonary syndrome. That is why there is increase in alveolar arterial oxygen gradient, right? And that is why we have hypoxemia. Okay, so what is happening in CLD or in patients with portal hypertension? Number one is when you have CLD or portal hypertension, this can lead to increased production of endothelin 1 by the liver. So liver has increased production of endothelin 1, and this endothelin 1 reaches the pulmonary circulation, and there it will act on endothelin 1b receptors which are present on pulmonary vasculature endothelial cells or pulmonary endothelium. Okay, now acting through this, right, endothelin 1 receptors, there will be increased expression of endothelial NOS or nitric oxide synthase. Okay, and this will obviously lead to increased production of nitric oxide. And we all know that this nitric oxide is vasodilatory. So this will cause vasodilatation of pulmonary vasculature. Okay, so that is the problem number 1. Okay, now what is the problem number 2? The problem number 2 is equally important. Not that endothelin 1 plays the central role. No, equally important is translocation of, what am I talking about? Translocation of gut microbiota. What do I mean by that? Now, in patients with CLD and portal hypertension, right, there is already change in the gut microflora, and these bacteria make their way into the systemic circulation. So there is bacteremia, in other words, and these bacteria can get concentrated in the lungs, because when bacteria enter the systemic circulation, obviously they are reaching the right side of the heart. Now from the right side of the heart, their natural next destination is lungs, right? And then eventually they will reach the left side of the heart and then other parts of the body, but lungs obviously get flooded with this circulating bacteria and also endotoxins produced by these bacteria. So there is translocation of gut microbiota and endotoxinemia. And lungs comes in the line of fire. So this can lead to increased accumulation macrophages and monocytes in the lung. Okay, obviously there is an important role of TNF alpha here. And see, once these macrophages are activated and monocytes are activated and they're flooding into the lungs, what will they cause? These will also, right, induce production of. So what do I see? There will be increased production of or expression of inducible nitric oxide synthase, and that leads to increased production of nitric oxide, right? Problem number 1. The second thing is the macrophage activation can also lead to, right, mainly using the TNF alpha, there can be activation of heme oxygenase, which will lead to heme degradation, and heme degradation will lead to increased production of carbon monoxide. Okay, now we also know that carbon monoxide is a potent vasodilator. So this carbon monoxide and nitric oxide both can contribute to pulmonary vasodilation, right? There is significant pulmonary vasodilatation happening, and we have to also remember that this activation of macrophages and monocytes lead to increased expression by vascular smooth muscle cells, increased expression of VEGF, right? VEGF A or VEGF alpha, and this will lead to angiogenesis, right? New capillaries and new blood vessels are being formed. Okay, and this angiogenesis can contribute to shunt formation. It is creating shunts inside the pulmonary vasculature. Okay, so basically speaking, my real problems with pulmonary hypertension is there is vasodilatation in the pulmonary vasculature because of two important mechanisms. One is macrophages indirectly leading to increased production of nitric oxide, and endothelin 1 by the diseased liver producing increased expression of endothelial NOS leading to increased production of nitric oxide. And the second thing is carbon monoxide as a byproduct of heme degradation also contributing to pulmonary vasodilatation, and increased expression of VEGF leading to angiogenesis and formation of shunts. Okay, now why there is hypoxia when there is pulmonary vasodilatation and shunt formation, that you will understand when you see through this flowchart. Okay, I'm again beginning from the starting point where patient has cirrhosis or portal hypertension, increased production of endothelin 1, activation of endothelin 1b receptors leading to more production of nitric oxide because of the eNOS expression leading to vasodilatation. Point number 1. Bacterial translocation, endotoxinemia, TNF alpha production leading to recruitment of monocytes and macrophages to the lung, and these monocytes and macrophages will have increased activity of inducible nitric oxide synthase leading to increased nitric oxide production, and heme oxygenase causing heme degradation and increased release of carbon monoxide. Both are vasodilatory. So we know why vasodilatation is happening. And the products of this monocyte macrophage activation will also lead to increased production of VEGF-A, which will lead to angiogenesis, new blood vessel formation, and that is what we call, that is what leads to hepatopulmonary syndrome. Now when we look at this picture, right, everything falls very clear. So what is happening in hepatopulmonary syndrome is there is dilatation of the pulmonary capillaries. So the normal pulmonary capillary diameter is in the range of 8 to 15 millimeters. Okay, but in patients with hepatopulmonary syndrome, this diameter can go anywhere more than 15 millimeters up to 500 millimeters. The average that is seen in most patients in autopsy series is around 100 millimeters. So when there is significant vasodilatation, right, the transit time through the capillaries is reduced. So the blood will quickly move through this capillary bed around the alveoli. So it is spending less time in this capillary bed, and thus the oxygenation time available for the gas exchange is limited. That is the problem number one. The second problem is because of the angiogenesis, right, there is a shunt formation as depicted in this image. Some of the blood is not coming in contact with the alveoli at all, right, because these are like new blood vessels, and it is getting shunted directly to the left side of the heart. So obviously it is not participating in the gas exchange. So both this, right, reduced transit time, right, faster transit through the capillary meshwork, and the shunting, both of these are contributing to increase in the alveolar arterial oxygen gradient, because alveolar ventilation is largely not affected until and unless there is an underlying lung disease also or a significant pleural effusion. Otherwise it is not affected, but oxygenation still gets affected because of this capillary dilatation and shunting. That is why we have hypoxemia. Clear? Okay, now we have understood the clinical features, right? Understood the pathophysiology. Tell me, what is the clinical feature you will expect? Hypoxemia obviously will cause dyspnea. Understood. Will these patients have orthopnea and PND? Orthopnea and PND, as we recognize, are hallmarks of left heart disease, right? These patients do not have any problem with the left side of the heart. As such, do they have a right heart pathology? The answer is no, right? The problem is within the lungs, right? So they are not expected to have orthopnea and PND, but they will have exertional dyspnea, and as the condition progresses, they will have rest dyspnea. Okay. Now, these patients generally will have platypnea. What do I mean by platypnea? It is exactly opposite of orthopnea, right? So these patients develop shortness of breath when they assume, or while they are assuming, an upright posture from the recumbent posture, right? Why this is happening? Now, when we lie down or when we go flat, okay, so when we lie down or go flat, the dependent parts of the lung, okay, see, now when we go flat, normally what happens, why we get orthopnea in patients with left heart failure or the abdominal pathology? One of the changes, diaphragm get pushed up, making it less possible for the lungs to expand, right? Lowermost portions of the lungs, I would say there is reduced air entry and the lung is getting pushed up, so the lung is partially getting collapsed when we are lying flat. Now, if you already have the alveolar edema, it will obviously cause hypoxia, right? Okay, now what is happening in hepatopulmonary syndrome is when you are recumbent, right, dependent portions are not getting dependent portions because of the push of the diaphragm, there is reduced aeration. Okay, so when dependent portion, there is reduced aeration, so then there is decrease in the alveolar ventilation, right? So you already have impaired perfusion or increased perfusion, normal alveolar oxygenation. So you had a perfusion, ventilation perfusion mismatch, but when alveolar oxygenation or air entry decreases in the recumbent posture, there is a VQ match happening, and because of this, the hypoxia is partially getting corrected and patients will not experience breathlessness. But when they assume an upright posture, right, you will improve the alveolar ventilation. Perfusion is already impaired, as we already know, right? There is vasodilatation and shunting. So clearly we are creating a ventilation perfusion mismatch when we assume an upright posture. So this will lead to perception of hypoxia, right? So that is why patient becomes symptomatic when they are upright. When they are flat, they may feel relatively better. Clear? Okay. Now coming to etiology, nothing to elaborate here. We already know, right? Etiology, the most common cause is cirrhosis of liver with portal hypertension. But we have to also remember that, like, this is the most common scenario. Any case with long-standing cirrhosis and portal hypertension can present with hepatopulmonary syndrome. But apart from that, patients with non-cirrhotic portal hypertension can also present with hepatopulmonary syndrome, and very rarely patients with acute liver failure might present with hepatopulmonary syndrome. So among these, acute liver failure is a rare cause, and most common cause is any cause of CLD or cirrhosis with portal hypertension. Clear? Okay, so that's about the etiology. Now coming to clinical features, pretty simple, right? Now we have a clarity. One, we can expect these patients to have dyspnea. Clear? Second, we will have platypnea. What is platypnea? As I've already told you, patient becomes breathless as he assumes upright posture from the recumbent posture, right? Okay, so that is platypnea. And then we also have orthodeoxia. Orthodeoxia. Now what do I mean by orthodeoxia, and how is it different from platypnea? Same thing here, right? Same manifestation as platypnea, but instead of perceived symptom of breathlessness, we are documenting objectively the degree of hypoxia. So when patients PaO2 decreases by more than 5% or by more than 4 millimeters of mercury on assuming or while assuming upright posture from recumbent position. From recumbent position, we call it as orthodeoxia. Numbers are important here. So more than 5% decrease in PaO2 or more than 4 millimeters of mercury decrease in PaO2, we call it as orthodeoxia. Okay, now apart from all these, patients might have features suggestive of liver disease, right? Like all the stigmata of liver disease, finding suggestive of portal hypertension, finding suggestive of hepatocellular dysfunction, all of them will be there, right? And there may be also other potential clues towards underlying cause, like KF ring in patients with Wilson disease, or bronze skin pigmentation in patients with hemochromatosis. Those are underlying causes for liver disease, right? Okay, so now this is about the clinical features. The simple take-home message is suspect hepatopulmonary syndrome in any patient with CLD who is hypoxic, right? Now, once you are suspected, right, we have to lead towards diagnosis. So the most commonly screening is done using pulse oximetry. So pulse oximetry is the screening investigation of choice. Pulse oximetry. And when SpO2 is less than 96%, obviously on room air, patient in sitting position, because in the recumbent position the symptoms may not be there, hypoxia may not be evident, right? Okay, now this will be like whenever you have a patient with CLD who is having some degree of dyspnea and his SpO2 is less than 96% in sitting posture, you can say the screening test for hepatopulmonary syndrome is positive and we need to go for definitive or confirmatory tests, right? So what is the definitive or confirmatory test? Confirmatory test for which the gold standard is bubble contrast echocardiogram, right? That is the gold standard. So what do we do here is, like, for example, what we do is we inject patient upper limb or arm with a agitated saline. So the contrast here is nothing but agitated saline. So some of the books also mention it as agitated saline echo. Now what we do is, like, take 9 ml of saline, use a 3-way cannula, right? So connect one syringe with 9 ml of saline, another syringe with 1 ml of air, and when you push through both, right, it agitates the saline and creates micro bubbles. So the saline is agitated to create micro bubbles inside that saline, which are more than 10 micrometers in diameter. Okay, now when I give it through one of the peripheral veins or arm veins, eventually where these micro bubbles are going to, so all those micro bubbles, right, if I'm giving into an upper limb vein, through superior vena cava will reach the right side of the heart. So right atrium will get all those micro bubbles. From there, obviously the micro bubbles will make their entry into right ventricle, and during the next systole, these micro bubbles will land up in the lungs. Okay, now normally what happens is, because the pulmonary vasculature, those capillaries are definitely smaller than this, right? They are smaller than this, and that can lead to accumulation of all these micro bubbles in the lungs, and they will get absorbed there, right? What are these micro bubbles? We had injected air, and air will get absorbed in the lungs. So barely any micro bubble will make its way to the left atrium. But if you have pulmonary vasodilatation and there is scent present, right, that means these micro bubbles from the lung can easily make their way into the pulmonary veins and reach the left atrium, right? So if they are reaching the left atrium, we can assume that there is pulmonary vasodilatation, and there is also presence of shunts. That is how these micro bubbles are reaching the left side of the heart. Right, now here we have to remember one important number. So these micro bubbles should be reaching, right? So these micro bubbles, right, reach left atrium within, or rather than calling within, and let me be a little more precise, between 4 to 6 cardiac cycles, 4 to 6 cardiac cycles after injection. Okay, now why this is important? I'm saying 4 to 6 cardiac cycles after injection. So that also already means that while you're injecting, the patient should be undergoing the echo, like simultaneously, not like I will inject and later I will take an echo, right? So patient's echocardiogram monitor should already be showing the cardiac activity or the chambers when you are injecting the agitated saline. Okay, now why 4 to 6 cycles is important here? See, when there was a problem, pulmonary vasodilatation, all the bubbles that came to the pulmonary vasculature, they did not get stagnated there, they did not get entrapped there, they made their way into the left atrium, right? So it indicates that there is pulmonary vasodilatation. But what if there is an intracardiac shunt itself? If there is a interatrial or interventricular septal defect, like there is an ASD or VSD, in that case, all these bubbles which came to the right side of the heart, right, they will enter. If there is an interatrial septal defect, they will enter into the left side, or if there is an interventricular septal defect, they will again enter into the left side. So they can become evident on the left side much before, right? To come to the left side through dilated pulmonary veins, they have to take a longer route. They will obviously take a little more time, but to get onto the left side, if there is a interventricular or interatrial septal defect, it is pretty damn easy, right? So when the bubbles are evident on the left side or left atrium within 3 cardiac cycles, it is suggestive of intracardiac shunting. When it takes 4 to 6 cardiac cycle, it is suggestive of pulmonary vasodilatation, right? I hope this concept is clear. So please remember this extra note here. Note, when bubbles appear or microbubbles appear in left atrium within 3 cardiac cycles, it indicates what? It indicates intracardiac shunting. Intracardiac shunting. When it appears between 4 to 6 cardiac cycle, it indicates intrapulmonary shunting or pulmonary vasodilatation. Okay. Now what else we can do alternatively? Gold standard is this, but alternatively what you can do is, as I've already told you, you can do a radioalbumin or like radioactive albumin tracer used lung perfusion scan. Okay, and here I have told you to remember one number, right? With brain shunt more than 6%. Okay, clear? So these are the investigations that we would be doing for the diagnosis of hepatopulmonary syndrome, right? First is screening. Yeah, I forgot to tell you one important point. After screening, obviously, ABG becomes important because ABG will help us to understand PaO2 for severity classification and also for the diagnosis or establishing the diagnosis of hypoxia, and it will also help us to calculate the alveolar arterial oxygen gradient. So ABG is an essential investigation when it comes to hepatopulmonary syndrome. Okay, so we have done with the diagnosis. Now one extra point to remember here is sometimes they might ask you whether transesophageal echo is preferable over transthoracic echo. Now the answer will be controversial because see, the diagnostic criteria using agitated saline says visualization of microbubbles in the left atrium. And what is the best way to visualize the left atrium? Transesophageal. But we have to remember here, we're talking about patients who have pulmonary hypertension. And when they have pulmonary hypertension or liver disease, there is a risk of presence of the esophageal varices, and there is an obvious definitive documented risk of increased variceal bleeding during the procedure. So it is not exactly very same. Theoretically, yes, that is a better way of looking at the left atrium, but practically it is going to be problematic for the patient. So most of us do a transthoracic echo rather than transesophageal echo. Okay. Now what you see here, this is how we see the agitated saline echo or bubble contrast echo, right? So then in this side, you can clearly see that left atrium, we have got all those bubbles. Okay, now those circles is not how the bubbles are going to look. It is it is circled for us to visualize the presence of bubbles. But yeah, when you see an image, you will clearly understand, okay, these are bubbles. Okay, so here, obviously, right atrium and right ventricle is expected to receive plenty of bubbles, and some of them have made their way into the left side of the heart. Now, how many cardiac cycle it took for the bubbles to be evident to the left atrium is the deciding factor. If it took 4 to 6 cycles, it is suggestive of pulmonary vasodilatation. If it took less than that, it is suggestive of intracardiac shunting. Okay, so the diagnosis is done. Now let us talk about the management. We have to understand that hepatopulmonary syndrome is an extremely fatal disease. Most of these patients, in the absence of liver transplantation, will not be able to pull through. And unfortunately, the only intervention that makes a difference with respect to mortality reduction is liver transplantation. Right, and in the MELD score, when it is 15 plus, the patients are listed for liver transplantation. In certain countries, when the diagnosis of hepatopulmonary syndrome is made, they get additional points and they are pushed further in the wait list for liver transplantation. Okay, so management wise, should we give them oxygen? Yes. Oxygen supplementation will make them little better with respect to symptoms, though we cannot expect them to have a major mortality benefit with oxygen supplementation alone. The only treatment that makes a difference is liver transplantation. Liver transplantation reduces mortality or increases survival duration, increases survival, and also increases quality of life. Okay, and the changes we spoke, right? A reasonable number of these changes will get reverted on liver transplantation between 6 to 12 months after the transplantation. So the pulmonary vasodilatation will start regressing. The angiogenesis or newly formed blood vessels will eventually disappear. Okay. Now, if there was a fibrosis triggered during the process, that will probably not be reversible, but most other changes will be reasonably reversed. And at the end of 1 year, most of these patients will have significant symptomatic improvement. During this period, they might require oxygen supplementation in addition to the liver transplantation. Okay. Now, if you ask me the question of what about the drugs, like plenty of drugs have been investigated, like blockers of HSatf, then immunosuppressants. None of them have proven a benefit in patients with hepatopulmonary syndrome. So all you need to remember is oxygen and liver transplantation. Everything else has no documented benefit. Okay, clear? Now, we have come to the end of the hepatopulmonary syndrome, but before we wind up the session, right, we also need to learn a little bit about portopulmonary hypertension. And just like how we defined hepatopulmonary syndrome, let me define it so that we understand what this entity is. Portopulmonary hypertension is nothing but pulmonary hypertension. And when I say pulmonary hypertension, obviously the diagnosis is based on mean pulmonary artery pressure. And what is the currently accepted mean pulmonary artery pressure for the diagnosis of pulmonary hypertension? Previously it was 25, now it is more than 20 millimeters of mercury, right? When MPAP is more than 20 millimeters of mercury, we say patient has pulmonary hypertension. So when patient has pulmonary hypertension, in presence of portal hypertension, portal hypertension, we will call it as portopulmonary hypertension. Okay, now the problem here, or the pathophysiology wise, what is happening here is that these patients who have portal hypertension, we already know that there is increased production of, so when you have portal hypertension or CLD, there is increased production of endothelin 1, and this endothelin 1, like, see, one way it can harm you is it can induce your vascular endothelium to produce endothelial nitric oxide synthase, but at the same time it can cause vasoconstriction, right? So endothelin 1 can cause profound vasoconstriction in the pulmonary vasculature. So this is the main difference between your hepatopulmonary syndrome. In hepatopulmonary syndrome, there is a vasodilatation. Here there is vasoconstriction, right? So obviously when there is vasoconstriction in the pulmonary capillaries, what will happen? Pulmonary artery pressure starts rising, right? So it will lead to increase in the pulmonary artery pressure. And this is what we call as pulmonary hypertension. And once the pulmonary hypertension ensues, right? So this will lead to pulmonary hypertension. So it started with portal hypertension and ended up with pulmonary hypertension. That is why we call it as portopulmonary hypertension. And this pulmonary hypertension will eventually lead to right ventricular hypertrophy and then right ventricular failure. So these patients will also develop, because of the pulmonary hypertension, they can develop dyspnea. And because of the right ventricular failure, they will have all classical features of the right side heart failure, right? Like your rise JVP, ascites, pedal edema, which may already be existing in these patients because of the liver pathology, right? Okay. Now, when it comes to management of these patients, there is slight difference because we have the pulmonary hypertension here and there is a vasoconstriction. We can think of vasodilators. So when it comes to hepatopulmonary syndrome, the vasodilators are going to be more problematic. That is why a clinical distinction is essential, right? Okay, so now this is one image that kind of summarizes the normality, portopulmonary hypertension and hepatopulmonary syndrome, what is happening at the level of alveoli and alveolar capillaries. So as you see normal here, normal ventilation, normal sized capillaries, which we know that it is 8 to 15 millimeters, right? Now, okay, portopulmonary hypertension. In portopulmonary hypertension, there is vasoconstriction. And in case of hepatopulmonary syndrome, there is vasodilatation, right? That is the basic difference. Now, clinical features wise, what these patients are going to present with, those who have the portopulmonary hypertension, obviously these patients will present with dyspnea, right? And they can have features of right heart failure. They will not have platypnea and they will not have orthodeoxia. So it is clinically possible for us to distinguish between the hepatopulmonary syndrome and portopulmonary hypertension. Okay. Now when it comes to management, obviously we are having pulmonary hypertension and we can think of treating these patients with vasodilators, right? We can use blockers of endothelin for achieving the vasodilatation, or other vasodilators can be used, like inhaled epoprostenol and all. So there are various ways or various vasodilators that we can use. Second, oxygen may be helpful for these patients too. And these patients will also derive benefit through liver transplantation. So the only thing to remember is that there is vasoconstriction and we can use vasodilators in case of the portopulmonary hypertension, but we cannot use vasodilators when it comes to hepatopulmonary syndrome. Clear? So with this, I'm signing off, guys. I'll see you in the next video module talking about another interesting topic on hepatology. Till then, have a good time.